Hello. All right. I hope I don't have to let people in because I was really bad about it last time. Okay, so today we are going to talk about some pharmacology of anesthesia and stuff. And so hopefully this will kind of ring some bells for you guys. I know maybe this is like things that you have recently talked about. Um, and I'm not sure exactly when you guys had pharmacology um, or even anesthesia end of things. I know probably surgery was one of your last classes that you had, right? But I know that when I had surgery and even talking about drug related things, it was hard for me to keep track of everything. And so I taught surgery and anesthesia. And so trying to come up with little crazy concepts um, was kind of fun for my anesthesia class. It was my job to kind of break them out of their shell in that class. So we came up with some fun ideas of remembering drugs and doing stuff like that. So I'm going to go through some of those with you guys to try to help you keep track of these medications or drugs. And hopefully you guys get a better handle on these medications so that you guys can take these meds and then put them aside so you can handle some of the other medications that are out there. We can categorize them better, and then you can kind of say, okay, I can handle pharmacology at least a little bit, because I feel like that's one of the big struggles is pharmacology. Um, and there's just because there's so many different medications out there, right? And people are like, what's an alpha 2? What's, an anticholinergic, and it's truly not that difficult once you finally get a hang of it. Um, so obviously, why do we treat pain? Why do we give so many different medications when we're going to do surgery? And I would always say in anesthesia, like, we love to play with drugs. That's our favorite thing. Like, why should we just give one drug when we can give 10 different drugs and they can play off of each other? That's the beauty of it, is that we want to balance it out so that we have all of the good things, and that the other drugs kind of decrease all of the bad things of the other ones. So that's the fun part. So why treat pain, obviously, is that we want to decrease, it should say decrease the risk of infection. I probably say this every time. I'm like, oh, I should change that because I'm wrong. We want to decrease the risk of infection. So obviously, if animals are painful, they are going to what? They do bad things to their body, right? They like lick incisions. I've even seen it on emergency ones where a little tiny cute fluffy puppy was left alone, of course, without an e-collar on in its kennel, and the owner came home to find the spay incision ripped completely wide open and guts out everywhere, and that dog died. Was it painful? Maybe. Um, but we never know, I guess. But obviously, uncomfortable enough for it to bother it, right? So We definitely want to decrease any type of risk of infection. Putting an e-collar on it is great for it not to be bothering the incision, but we also want to make sure that they're just not painful. By just putting an e-collar and saying, okay, don't bother it, they can still be painful. You know, we have to make sure that they're not painful and staying away from it. Delayed wound healing, right? So in order for them to, sorry, I want to make sure I get rid of that. You know, if they are not eating because they're painful, that's going to delay the wound healing, of course. And so if they are bothering it again, that's going to delay that wound healing. If they're, again, reduced water intake, food intake, immobilization, if they're not moving, that's not going to help. They can have altered sleep patterns, abnormal behavior. If they've never bit anyone before, now they're starting to bite people. And then obviously increased post-op complications from licking, bothering, stuff like that. Nociception, you guys remember what all that was about? Nociception, yes, right? So the idea and the perception of pain in the body. So someone goes to slam something on your hand and you just perceive for that to hurt, but maybe it didn't actually hurt. Or say like phantom pain. You guys hear of phantom pain? Yeah, the idea that it necessarily hurts. So you could even put like your arm around that box and then have a fake arm, and someone pokes that fake arm and you may have that nociception as well. So, oh gosh, alive. Facebook. Okay. And then it can be further divided in somatic pain versus visceral pain. So what is somatic pain? Where is that located? My favorite, these divisions. Somatic pain would be in like bones and joints. And then visceral pain is in like body cavities. So like your thorax, your chest. I just said the same thing. Thorax and abdomen, okay? So like your guts and stuff like that. So when I say visceral pain, I always think of like, oh, Serenia, it's so good for visceral pain, okay? And so, which is actually true. But think, Serenia is good for vomiting, right? Which goes into your stomach. It helps with your stomach, so it's visceral pain. But it also is actually really good for visceral pain as well, because they have done a study on it in like 2009 versus morphine on spays or canine spays, and they both equaled each other in visceral pain. And because Serenia blocks substance P in the brain. So a lot of people also use Serenia in their pre-meds for that as well. So not only just for that anti-nausea effect, but also for that pain as well. Not solely alone they have done it, but they are putting that into their pre-med as well. So remember, visceral pain is for your organs, organs being thorax and abdomen, and somatic pain being bones, joints, stuff like that. And then we further break that down to superficial pain and deep pain. And so now people start going, oh, I know what superficial pain versus deep pain is, right? Superficial pain would be like your paper cut. Hopefully it's just a superficial pain. And then deep pain would be, when you hear deep pain, you think of what kind of animal or what kind of disease? Guys are so quiet. Like IVDD dogs, IVDD. You're in those dachshunds that blow discs, right? And they lose motor, and then that deep pain they sometimes lose. So you really go to pinch that toe, and you go to see if they feel that deep pain. You're really pinching hard to see if they feel that deep pain. And if they do feel it, fantastic. If they don't feel it, they don't have that pain, that deep pain, then we really have to have talk with owners of like, okay, chances of success from this or that. I mean, it's not like horrible, obviously, but that's a whole other story. But it's deeper, obviously, than that superficial pain. So this is just going into somatic pain versus just somatic pain versus visceral pain, which I do have this PowerPoint up for you guys on Vet Tech Prep site for you as well. And then, you know, pain is determined a little bit differently too. Like, do you have shooting pain? Do you have gnawing pain? Do you have acute pain versus chronic pain? What does acute pain feel like versus chronic pain? Acute pain feels like what? Like, what would your pain feel like right now if I just came up to you and broke your arm? What would that feel like? Would that feel like a really sharp pain, or would that feel like a gnawing pain? Anyone? Lisa, come on.
Sharp.
Sharp pain, good. Yeah, it would be super sharp, and you'd be like, oh my gosh, Beth, I'm gonna punch you if I didn't have a broken arm. Awesome. Now, if I had chronic pain, how would that feel? Does anyone have chronic pain? What does that feel like?
Dull.
Dull, like, yeah, it's a dull pain. So that's our pathway in our brain that is saying, okay, like our body is tired, it's a tired pathway, right? So that's kind of how we essentially, our pathways work. So this is a nice little graph of like how our nociceptive pathway works versus neurologic or neural pathway pain works. And this is how we can determine what pain medication is going to work best for our animals. So we can't just be like, oh, morphine for all is going to be perfect, because that's not really what everyone is suited for, you know? So it's kind of funny because some people think that, oh yeah, morphine's going to cure everything, which sometimes an NSAID is actually going to be more beneficial than a opioid. And sometimes our gabapentin is going to be better for our neuropathic pain. So it's really good to know, okay, where's this pain coming from, first of all? And is it acute or is it chronic pain? Where it's coming from as well. So that's kind of why we need to have that baseline knowledge of it. So back to preemptive analgesia as well. So now we'll get into the drugs as well, but it's a good understanding of having like, all right, what is pain itself? So preemptive, why do we want to treat it right away versus wait till it gets really bad? Is because it is extremely hard to treat it and get it down to a regular level if you wait. So if we start right away, then we don't have to get that wind up. You know, wind up is crazy. So if we give meds, we can keep it at bay, right? So if we can give some pre-meds and keep it at bay, then we don't have to give whopping doses of medication. So that's the nice part. So the wind up theory itself. So if you've ever heard of hyperalgesia, which is also termed as central sensitization, gosh, I can't talk. It's also known as fibromyalgia. if anyone knows anyone with fibromyalgia. That is what the wind up phenomenon is. So that is what we're trying to avoid. Wind up is not fun because, again, it's really hard to bring someone's pain level down when it's fully wound up. Okay. And so I'm going to skip this guy's TED talk because we don't have all day. This is from like when I was teaching. So what we want to manage. So hopefully you guys talked about balanced multimodal anesthesia or even analgesia. So that means using 2 or more drugs. You guys talked about this? Yes? I'm going to take a no answer as a good answer. So we want to do is as a synergistic effect. So having the best qualities of those drugs work together to balance out those bad parts of the other drugs. So let's take ketamine and diazepam because you guys should know those guys, right? So ketamine has some good qualities and it also has some really bad qualities. So bad quality is that ketamine makes you extremely rigid. And we definitely don't want to do surgery on an animal that is very rigid, muscles being very tight and tense. And so the really awesome thing about diazepam is that it has a great quality of that it's a muscle relaxer, right? So it's going to balance out that ketamine. And that way we can have a great an induction medication to give our animal. So that's what we're talking about of a balanced multimodal analgesic or anesthesia. Okay. Some other things that we've done too is like midazolam and propofol. Okay. So people have used propofol for a very long time. So propofol doing propofol just as a whole dose. But what's one really bad thing about propofol if you give it too fast?
It causes excitability.
Okay, so you are going to see the excitement phase as a stage 2 for when you're doing induction, regardless of what medication you're giving, yes. But if you give propofol too fast, what is one adverse side effect that you'll see? It starts with an A. It means stop breathing. Apnea?
Apnea.
Good. Great. So, so what we have found over time is that if we give a dose of midazolam prior to our propofol, we can lower our dose of propofol and it reduces then the risk of having apnea. And it's been working fantastic, obviously. And so many places have adopted this protocol to lower our doses, obviously, of drugs itself. And then obviously we feel safer using this and not having that increased risk of apnea. Very good. And obviously you don't have to use midazolam. You can use diazepam. You can use dexmedetomidine if you want. There's so many other medications, but obviously that's just one that we had been doing. So some of our pre-medications that we have done in the past and diving into what categories they go to. So if you don't have a handle on this, and I will even post a cheat sheet that I've used in the past of organizing these guys for you to kind of help. get you guys like looking at these more and more, so that you're ready. And when you're looking at your VTNE, you're like, okay, anticholinergic, that can only be a couple of these drugs. But what I do is when I'm talking about these, so anticholinergic, we have two drugs that we typically use in pre-medications, and they are atropine and glycopyrrolate. All right. And so the reason why we only have these two, and the difference between these, is that one of them, and I talk in terms of a distance runner and a sprinter. Okay. So there's one that is very fast onset, like a sprinter, but doesn't last that long. And then the other one is a slower onset, but it paces itself and it lasts longer. Okay, so a lot of these drugs are like this, and then they're paired together. And so atropine, and we think of atropine as our drug that we use in emergency situations, right? So we already know atropine is going to be the sprinter in this case. So we don't have time for glycopyrrolate because glycopyrrolate takes forever to work. So atropine, if you guys look, it has a very quick onset if given IV. And I almost sometimes hate using it IV in my surgeries, because I have already worked on turning them down so many times because their heart rate's so low. And then all of a sudden I give it IV, the atropine, and then they try to jump off the table because they've gotten this kick, you know, and they've been lightened up and everything too. So I have to keep that in mind, is like, okay, I am now giving them atropine and I need to turn them up again because they're going to jump off the table. So it just works so quickly. But atropine is our quick working machine, but it doesn't last that long IV. And so we use this for bradycardia. It does not jump start the heart though. So if you are thinking on terms of my animal is dead right now, and the heart is not beating, we have to give it something else first, right? So that is when we're going to give our epinephrine first to start that contractibility, of the myocardium. And then once we can actually get the heart pumping, and at least some type of heartbeat, then our atropine should start kicking in. Okay. Glycopyrrolate is a drug that we can actually use for as an anticholinergic for longer pace surgeries. You know, it was really nice when we were doing like any type of neurology type surgery. So our IVDD dogs, it's good. You know, I can't say we did some craniotomies and I did post-ops with them, and I can't say that we would do them on that type of dog, but if there's any long patients that needed it, so even some orthopedics, I would say, but longer type surgeries would need those. But anticholinergics too have some other things that we have to keep in mind. So the effects that we want to keep in mind too is that they dry other areas up, right? So they dry up secretions, correct? So that's important to remember. So sometimes some doctors will give a tiny dose of an anticholinergic prior to surgery if an animal has had any type of hypersalivation, a crazy amount of GI motility. They may give a little bit of an anticholinergic, even if it's a quarter dose of an anticholinergic. So that is something to keep in mind. They also will have an effect on the iris of the eye. So if you get atropine in your eye, it will dilate your pupil. So what is dilating of the pupil called? Remember? Oh, this brings you back to like med term. Mydriasis.
Dilation of the eye.
Yeah. Mydriasis. So you may have to at some point put drugs down an ET tube. And so there are a number of drugs that you can put down in ET tube. And those drugs that you would put down an endotracheal tube is, say you can't place a IV catheter. Those medications would have to be doubled than the regular dose. And make sure that you would actually flush that down with, like, you know, some people have blown into the endotracheal tube, but just an ambu bag, put the ambu bag on. I actually worked with a coworker who went to blow into the tube and she just like blew in from far away and the drugs splashed up into her eye, and it was atropine that splashed into her eye. And so the atropine dilated her pupil for like 48 hours or something. And so she had like a calculus exam the next day. And so it was a pretty tough exam for her to take. So, but do you guys know the drugs that you can place down the endotracheal tube? There's 5. No? All right, let's see if I can write. So, no, I just want to write. Okay, so I already know how to do this, I think. Okay, so there's 5 drugs. Have you guys seen this ever? No? Okay, so there's 5
I
drugs.
don't see what you're writing.
No? Okay. Thanks for telling me that. Maybe. Hold on. Oh, there. I think I have to. It's like very weird. Okay. Do you see this?
Yes. Yes.
Okay. I'm still getting used to this whole thing. Okay, so have you seen this before?
Nope.
Okay, so all right, there's 5 drugs that you can give down an endotracheal tube. And so they spell navel. And these drugs that you can give are naloxone, okay, atropine, and then vasopressin. I spelled that wrong. It's hard to know how to spell writing down. This one would be lidocaine. And then what about this one, you think?
Epinephrine.
Yay! That's it. And now you can be an emergency and critical care person. So those are, and this is on a separate tangent because this is nothing, well, I guess it has something to do with anesthesia, because you should have a crash cart in your surgery area. It doesn't have to be in your surgery room, but those are, I think, the important drugs to have near and dear to your surgery patients, especially in case something happens. So, yeah. So back to, sorry, I got off on a tangent. I can never leave my roots of critical care. So anyway, so we were on that. So I call these guys big brother, or I'm sorry, big sister, little sister as well sometimes. So it's funny because I would have students that would be like, oh, the big sister's glycopyrrolate and the little sister is atropine. And then other teachers would be like, what are you guys talking about? And I'm like, never, don't worry about them. They just, that's how they learn. So yeah, so long distance runner again is your glycopyrrolate, and atropine is your short distance runner, or if you want to do little sister, big sister. And now for my drug I hate the most coming up is acepromazine. But my husband's laughing at me because he knows. And then, so we're talking about phenothiazine tranquilizers. So these are not controlled substances, although you do see acepromazine kept in the controlled drug box a lot of times, just because we use acepromazine a lot with other controlled drugs, usually because they're in our surgery pre-meds and stuff like that. So, but it doesn't have to be in our controlled drugs. There's no analgesic effect to these guys, and they are metabolized by the liver. So I can say that if you do overdose an animal on acepromazine, it will take a very long time for them to wake up usually, and they are pretty droggy from it. I did have a coworker give 1 ml of acepromazine to a Weimaraner once, which is a lot. And there is no antidote or reversal to acepromazine, so you have to be really careful. Luckily, it was a Weimaraner, so they are already crazy. So they actually did okay with it, but it does just take a long time to get out of their system. So this has been previously used as a common drug for thunderstorms and fireworks and whatnot, and talked about as a drug for anxiety. However, it does not reduce anxiety one bit. It just makes human beings feel better because their dog is knocked out from the drug itself, just like Benadryl, right? Benadryl has no anti-anxiety effect. It just knocks your dog out. So we do have better options out there, right? Like we do have so many other options that we can choose from, which you guys, I hope, have learned over the course of your last couple of years in school, correct? Or have seen. You know, like cats have the glorious gabapentin. We have trazodone that's out. Even Prozac, you know. There's so many amazing drugs out there. And that's why I have my presentation here today with my dog. The whole pain thing with him on the front, it was because he was a pain in the butt. And so anyway, we know we have better choices out there. Okay. Acepromazine also lowers, people say it lowers the seizure threshold. The theory's still out on that, but it does lower bite inhibition. So you have to be careful with this drug, because an animal that has never bitten anyone before now has gotten some acepromazine, and could bite you now. Why? Probably because they're sedated and they don't really know what's going on, would be my guess. So we have to be really careful when we are giving these drugs to them, that yes, they could potentially bite when they're not normally a biter. So and then yeah, be careful on overdosing these animals, especially the little guys. And be comfortable using insulin syringes. And you guys learned how to use insulin syringes?
Yes.
Yes, good. They're so easy to use, right? U100 is just a 1 ml syringe. So 30 units is 0.3 mLs. So yes, be comfortable with using it. That was another thing I taught them. So we do have to be careful again with acepromazine in certain breeds. And boxers are not scientifically proven. It was actually just a breeder thing that they said. The reason for why we are careful is because boxers do have an underlying, I shouldn't say usually, they do at some boxers have heart issues, and so we do just have to be careful in those boxers that do have heart issues. We do have to be careful with MDR1. I call them MDR1 mutants, but mutations, because that is scientifically proven. So whether or not we know that they have been tested, which now is a little bit easier to have them tested than it used to be. There are a lot of drugs out there that you have to be careful with giving. So it's a good idea to have a list in your practice of those medications that don't cross the blood-brain barrier very well, so that you know what those dosages are that you cannot go over and stuff like that. Metronidazole is a good one as well. So they are not to be messed with. Chlorpromazine is not really used as much anymore. It had an antiemetic effect, and we used to give it in cats at times, but there are better drugs out there now. But it's good to note that it had an antiemetic effect, and it also had a sedative effect too, which is always nice in cats, right? So that's where we are for those guys. But again, like I said, we don't really use chlorpromazine that much. Now, benzodiazepines, all right, so you guys all know benzodiazepines, that goes with diazepam and midazolam, right? So again, we have our short distance runner and then our long distance runner. So diazepam is the short distance runner and midazolam is the long distance runner. So a lot of times we'll give diazepam because, well, for a while it was cheaper, but I guess now midazolam's cheaper, so people are getting midazolam. And but we love diazepam because it does cancel out some really bad things with like ketamine and some other stuff too, even with dexmedetomidine. And but there are some really bad things too with diazepam. So diazepam is actually light sensitive. Um, it binds to plastic. So if you put it in a syringe and you leave it for 4 hours, some of that drug has been absorbed out. So you'll have to throw it away. So if we put an animal on a diazepam CRI because it's been having seizures, you have to change that syringe and the whole line every 4 hours. So it wastes a lot of that medication. So the nice thing is that midazolam does not bind to plastic, right? So that is the one positive thing that we can take from midazolam. Another thing is that one of them is lipid soluble and one of them is water soluble. Do you guys remember which one it is? Wait, I always have it written out somewhere. And then you guys can find it. No, I don't. Okay. So which one's fat soluble and which one's water soluble?
Diazepam is fat soluble and midazolam is water soluble.
Good job. That means I can give which one I am.
Midazolam.
Awesome. Look at you. Very good. So that means if I have a naughty dog or a naughty cat and I can't give it IAV for anything, I can give midazolam IM, right? So that's super nice. And did you guys know that you can give these guys, rather than rectal diazepam or midazolam if they're having a seizure, which I don't really know how you get this close, but you could give them nasal diazepam or midazolam. Very true, but I've never done it, so I'm like, they'll probably bite me, but I'll try. So yes, so diazepam, it works really fast, but it doesn't last very long. It lasts about 20 minutes long. It also is an appetite stimulant in cats. If you use it frequently though in cats, it can cause some hepatic issues. So you just have to be careful, obviously, and have their liver function tested and like quite frequently. Now, diazepam, a PO treatment for them, it is a PO treatment for them for inappropriate elimination. Usually is like one of their first treatment options, but as like a behavioral therapy, but it doesn't always work. So it's one that they try. And is usually used as an induction agent. And then midazolam, we use it a lot. I used it a lot when I was teaching too, because it gave students a nice long time to be able to, look for intubating. You didn't have to necessarily hurry. It also is fantastic to do CRIs like I was talking about because it doesn't bind to plastic. Also, for your benzodiazepines, you do have an antagonist, right? So for your opioids, you have an antagonist. Your agonist, how I would describe it is, okay, your agonist is a 16-year-old kid who wants to sleep in, right? Because we're in a pandemic right now, and all they do is, they're sleeping every single day because there's nothing else to do. They're an agonist. And so these drugs are the same thing. All they want to do is fall asleep. Now, the antagonist is they're the 5-year-old kid who is antagonizing the agonist. So what their job is to do is to wake them up. And so that's how you can make the difference between antagonist and agonist, is that antagonist is there antagonizing them. So flumazenol is the antagonist to all benzodiazepines. So whether it's midazolam, diazepam, zolazepam, any of the PAMs, essentially. So flumazenol, if you've ever seen it, not everyone carries it at their practice. Luckily, we haven't had to use it before. When I was in practice, we had it in our shelves. Some have nasal spray in like the human field. And if you have an overdose, you may have to do multiple doses. But usually our drugs don't last that long in our system for benzodiazepines that we really don't need it. So that's a good thing. But it's nice to obviously, and it's important to know what your antagonists are. So flumazenol, remember. All right, so our alpha-2 agonists, so these are like one of my favorite ones to remember. So you have two alpha-2 agonists that we talk about. and then 2 alpha-2 antagonists. And you have to remember which ones go to who, right? So you have, which ones are your alpha-2 agonists? Do you remember? Do you remember? So like my favorite. I named a baby after one. Dexmedetomidine, good. So we have dexmedetomidine, and then another one that's kind of towards the end of the alphabet.
Xylazine.
Xylazine, good. So we have those 2 alpha-2 agonists. Very good. So they have heavy sedation. Some people don't like using them because one thing is that they will have a very low heart rate at times. And then they can also have a low blood pressure, so it's important to monitor both. What's really important, though, is that your cardiac output does not just equal heart rate, right? So we do have to monitor both. So just because maybe you have a border collie that comes in and their heart rate is 40 and they had an alpha-2 agonist, does not mean you're in danger, right? If you then check its blood pressure and its blood pressure is completely normal, say its blood pressure is like 100 over whatever, it's 100 on a Doppler, then your blood pressure is completely fine. It's just as a result of your alpha-2 agonist. So you shouldn't necessarily be as concerned that, oh, my heart rate's only 40. Your cardiac output is completely fine because the blood is getting everywhere it needs to go based on your blood pressure. Now, it is a little, concerning if it continues to stay that low, and that kind of stuff. So if it does stay that low and you are concerned, what do? You have bradycardia, right? So what do you do if you have given an alpha-2 agonist?
You reverse it.
You reverse it. Good. You don't have to give atropine, right? That's the big no-no on that. So very, very good. Some people say you give atropine and then I have to throw something at them. No. So very good. Also, say you have an animal who comes in is super, super high stressed, all right? And then people want to give an alpha-2 agonist. And so there are times where they get so stressed that no matter how much they give of an alpha-2 agonist, it will not bring them down. So they're probably going to need to do something else other than that alpha-2 agonist. So yeah, it just is not going to work. So just be wary of it. And so it is also important to know that this is a drug that is only a sedative effect, and that they still are going to be sensitive to sound and to light. And so say you're doing like a laceration repair, or even just like a nail trim because they don't like their nails cut or something. It is incredibly important to be conscious of, okay, they're going to be, worry about the sound or what's going on. So if you can't have these animals, or if you can't have the sound be soft for them, like putting cotton balls in their ears, putting a towel over their eyes so that it's light or darker when they're starting to wake up and stuff, and that they don't have to wake up where it's like completely crazy because that's a lot for them to have to handle. You want them to wake up soft than wake up in a frenzy. And then xylazine. So xylazine is in old terms, or in the trade name is called rompin. So if you are even in large animal, they refer to it as rompin. And then we try to go based on the generic names, of course, as much as possible, because you'll see even in like NSAIDs are like carprofen has like 8,000 trade names now. So, but these guys, xylazine is um, used in 2 different strengths, so you have to be careful in large animals, more concentrated strength. Xylazine also is our go-to for making cats vomit. So that is what we use. Apomorphine is what we use for dogs as well. And dexmedetomidine is our drug that's 10 times more potent than xylazine. And then the dosing for it is based off of body surface area, which I'm not going to get too crazy involved in. We do a bunch of drugs in body surface area. It's actually more, it's it's just more accurate. That's how we calculate chemotherapy drugs. So if anyone's thinking of going into medical oncology, you can definitely do that. The really nice thing is that this drug, so you don't have to learn body surface area, which is not that hard. It comes with a chart. So you could just look up like weight in kilograms or weight in pounds and then look at the body surface area. So it's easy. We use this a lot of times in conjunction with other pain medications and other sedatives and stuff like that too. So it is a really great drug to use and everything. This is Celio. Have you guys heard of it, used it, seen it? It is dexmedetomidine, just in a paste form that was used for noise aversion in dogs. And dexmedetomidine has a little bit of like a behavioral calming effect. It's not really my favorite, but I mean, I'm putting my opinion out there. I think there's other drugs out there that are have better potential, but some doctors like it, some don't. I mean, I think it's just up to the person. And also the pet. Like maybe some pets are not as bad as others and that kind of thing too. So I think it just depends. But this is a newer drug that came out in 2016. And when they first brought it out, there were quite a few overdoses on it, and I think it was due to human error of using it. So, but there were no deaths related to it, so thank goodness. But since then, they have, I think, redid like their mechanics of the syringe that's on there. So, but I have not heard really crazy amount of like, oh, this drug is amazing kind of thing. So, okay, and then our alpha 2 agonist antagonist. So I usually just kind of try to say like, guys, these are the antagonists, because to say agonist antagonist for you, that's just a lot. But so to match these up, and how I had my students match it up was, think of dexmedetomidine as in the beginning of the alphabet, right? And oh, sorry, I'm making noise. It's in the beginning of the alphabet. So dexmedetomidine is the beginning of the alphabet, and then antipamazole is also the beginning of the alphabet, right? So they go together. And then our next one, xylazine and yohimbine, my favorite drug. I named a baby after it. Not my baby, somebody else's. One of my students. Go together because they're at the end of the alphabet. So xylazine and yohimbine go together because they're at the end of the alphabet. So that's how you know which ones antagonize each other. All right. So etapamazole is antecedent. And all of you guys who have worked in practice probably have seen dexmedetomidine and etapamazole, or dexdomitor and antecedent. We probably know it better that way because not many people refer to it as that. We don't usually give antecedent IV, and we give that necessarily IM. And then for dogs, we give an equal volume, and then cats, we usually do about a half of the volume and let cats wake up nice and slow. Usually that goes much better for all of us involved. And then yohimbine, we give that IV, and you can give the complete reversal for that. All right, so opioids. I'm just going to run through this pretty quickly because a lot of them are pretty simple, and then we can kind of finish up the next time we talk because I know there's so many drugs. So opioids are interchangeably called opioids or narcotics. So we have our antagonists are naloxone is a full on antagonist. Butorphanol is partial, and then so is buprenorphine is a partial. But buprenorphine cannot be reversed. Okay, so buprenorphine was originally made for human medicine, I guess you'd say, as a drug like methadone to control addiction as well. And obviously we use it for pain control in veterinary practices too. So, but here's a bunch of the opioids that we can use. We don't all use in practice, and there's just a few that I kind of highlight. And some people call certain ones by their trade name versus generic name and stuff. So what do? Obviously, they help decrease, obviously, multiple degrees of pain, anxiety, and then it depends, obviously, on certain species of how well they work. Are they agonists versus partial agonists and antagonists and that kind of stuff? So we have 4 receptors in our brain to be able to, or opioid receptors in our brain. So essentially it's like a puzzle piece on how these drugs work, on if they're going to fit that puzzle piece to be a full receptor to blocking that pain 100%. And so there aren't a lot of drugs that actually fit all 4 puzzle pieces. There may be a partial agonist, so they fit that partial puzzle piece, or an antagonist is something that just blocks so that nobody can fit the puzzle. And then there also can be, of course, the full puzzle piece would be like morphine that fits it. And yeah, your partial does. So that's kind of what I just described to you there. So and then the ceiling effect. So the ceiling effect means that there are certain drugs that no matter how much you take, it will not allow you to reach any higher than that pain control. So like buprenorphine, you can give that calculated dose that you have, and that's as much pain relief that will give you to your patient. So you will have to then find a different medication to give a better effect of pain control. So which is kind of a good thing, because then that patient can't overdose on, buprenorphine essentially. So say you send home an animal on buprenorphine oral meds, and the owner decides to give like 2 or 3 doses at the same time because they felt that they were overly painful, then you don't have to worry essentially about like an overdose or something. And then some side effects. So morphine mania, whether or not you've seen some cats, that received some sort of morphine derivative wake up and they're just like looking crazy at you and stuff like that. Horses can be the same way. Also, morphine derivatives can cause respiratory depression, which I know was something that we talked about. We were talking about alcohol. That's what it was on our Vet Tech group, where you have respiratory depression. But same thing for opioids as well. It kind of is like that you're just so stupid that you forget to breathe. And so that's why we don't want to knock them out that much, because we don't want them to forget to breathe. Also, a really interesting thing is that opioids also alter their thermal regulating system. So they can get a really, really high temperature. And so you'll have, especially cats, come back from surgery and they will have a temp of like 105. And so you'll see probably in practice, people will pull out all their bedding and put ice packs in their cage. And you don't have to make a big deal about it. It's just due to their morphine that they had. And I always think that's mean. I'm like, give them their bed back. Like, I can't help it. It's just their morphine. You're making them uncomfortable and they just had surgery. So and then also effects on their gastrointestinal system. They can be nauseous, hypersalivating, especially when you give morphine. So also giving them Serenia in conjunction with that would be awesome. And then decreasing cardiac output, of course, and morphine especially gives a histamine release. So this is why we really don't want to give it IV. You get a huge histamine release, and that's why you see a lot of people itching like crazy all the time when they get morphine, is because they get that histamine release so much. I actually had morphine once after a C-section, and I thought I was gonna itch my skin off like crazy. So anyway, morphine is a Schedule 2 drug. Important for you guys to know too, since you're almost out in the field or already in the field, all Schedule 2 drugs need to be in their own separate logging system than 3s, 4s, and 5s. So that is really important to know that you're logging them separate in any fashion for like the DEA if they ever came in. Okay. And a lot of times they use morphine in our epidurals. Um, if you do any of epidurals, which would be awesome. Hydromorphone is 4 times more potent than morphine. And we use hydromorphone in moderate to severe pain cases, usually in exploratory surgeries or orthopedic surgeries like cruciate repairs and stuff like that, if you're not using fentanyl or anything. And then you can see bradycardia. You also can see some respiratory depression, but a lot of times you'll see hydro cause some panting, if anything. So that's one of the big signs. So also knowing what pain meds not to give for certain situations. So say you have a hip card that comes in, maybe a drug not to give is hydromorphone. Because you don't want that animal to pant until you can clear them from any type of chest issues at first. Fentanyl. So fentanyl was on a class 1, or I'm sorry, schedule 1, until February of this year, due to the street use of fentanyl, because it's so unregulated of whether or not it's 102 to 150 times more potent than morphine. So it is being very, very closely monitored, but it is a Schedule 2 drug. It's very good for severe pain, but it has a very, very short duration of action. So we use it a lot for CRIs or transdermal pain, and animals have a very higher, they can take much more higher amount than we can. So you will see them having bigger pain patches and stuff like that than we can. So fentanyl patches, it does take them about 12 to 24 hours to take effect. And it is very, very important though that when we put on those those fentanyl patches, that we are still giving them pain medication in the meantime. So if you are giving them like buprenorphine in that meantime, it also is important to discontinue that pain medication, especially buprenorphine, after that pain patch has started kicking in. remember, buprenorphine is a partial antagonist, and so if your fentanyl patch kicks in, it's going to antagonize your fentanyl. So then your patient's not going to have any pain medication, right? So we need to kind of think that one through and make sure, okay, we're de-seeing our or discontinuing our buprenorphine so our fentanyl patch can kick in. And then I'm monitoring them for any kind of pain if they have it. And then buprenorphine is a Schedule 3, okay, and this is for moderate pain. And it cannot be antagonized by naloxone. Remember, buprenorphine is the only opioid that cannot be antagonized by anything, but it does antagonize fentanyl. So it's one of those tricky drugs. The nice part about it is it doesn't really cause any kind of GI issues, so that's so nice. And we use it a lot for like any type of post-trauma. There's a newer drugs out there like Cymbalta, and it lasts for 24 hours. There's also another compounded one that lasts for 3 days, sub-Q, that we can give to cats and stuff, so you don't have to send home those pre-syringed buprenorphine drugs. It just is a little bit costly, so you have to be careful on that. Butorphanol, so these are things that we talked about on the post page 2. It is a synthetic opioid. It doesn't have a great analgesic effect to it because it only lasts about 45 minutes for pain meds. But it does help better with visceral pain than somatic pain, so better for our chest and abdomen pain. And then it does have a better sedative effect to it, just a calming effect, really. And then it also is a good cough suppressant. So, but we do have a sealing effect to it as well. All right. And then tramadol, we're learning so much more about. So it is a Schedule 4 drug. It used to not be controlled years ago. Oh gosh, this is probably 12, 13 years ago. It was just like on the shelf. And finally they made it controlled. But it is a post-surgical or chronic pain medication. We're finding that it really isn't that great of a drug used by itself, and that we do use it in conjunction with other medications like gabapentin and maybe even an NSAID or stuff like that. So osteoarthritis pain, other meds that we use are Galliprant and other, you know, NSAIDs on that nature, which we can talk about at a different time because we are out of time. So those are kind of the main drugs that we use injectable wise for surgery. Other ones that obviously we can talk about too is like propofol, Faxone, stuff like that. But the bigger ones that we use essentially are those different class drugs and making sure that they're categorized in the right category so that you know too, okay, what do each of these drugs do and can I put them in the right categories? So I hope that has helped at least a little bit. Do any of you have questions for me?
I don't have any questions, but I really appreciate you taking the time to do this because there's definitely things that you said in your presentation that we did not go over specifically in our lesson. So
Great.
I appreciate this.
No, I appreciate it. Yeah, and let me know if there are certain things that you guys need focused on or want focused on, because I'm kind of just going with things as I go along. I have done a VTNE prep course when I taught before, so I'm kind of going off of things like that I've done too, but I don't want to obviously just self-guide unless you guys need something specific, because I know some of you are on a time crunch for sure in taking your test soon. So you guys let me know.
And
Now-
one of these days we go over reading EKGs. That is something that I find we didn't really cover
Yes.
in
Yeah.
college that I'm definitely struggling with.
Yeah, absolutely. Yeah, and I can tell you, you guys will, especially for ECGs, it will take you a long time to um at least feel confident in an ECG reading of stuff, but you guys should feel at least a little bit better at, okay, like if these P waves look weird, I know this is coming from the atrium and I can narrow it down to at least these few things that could be wrong, so being able to narrow things down is important, and then kind of going from there versus I have no earthly idea what I'm doing. So yeah, but being able to calculate heart rates and stuff like that, you guys should be able to do that in your sleep. So I know we've done some practice ones on that, but I know we could do that for sure. And then yeah, I think let's do that for our next session is like ECGs and stuff. We can always come back to drugs and all of that too. So, but yeah, if you guys have suggestions and you want to message me of like what you really want to learn, I know someone else mentioned, I saw in one of the forums too of CRIs, that they were nervous about CRIs being on the VTNE. We can do a few of those too, because they're not too bad. It's truly just about conversions and then figuring out from there. But that way you guys feel a little bit more confident. But yeah, just let me know like what you guys want to do out of those, and then truly another part is practicing how to answer these questions, and then how to read the questions, not necessarily just reading the question itself first, but even reading the answers first and saying, okay, what do I think they're going to be asking about this question right now, and narrowing it down from there. Like, what about these answers are essentially similar? Maybe something out of here doesn't look right off the bat, and then looking at the question next, and trying to whittle things down right away. So, and then, if you guys have questions based on those little quizzes I give out to you, a lot of those questions come from like BTNE prep stuff. So, I was not nice to my students. I made it hard for them.
Not really.
So yeah.
Question revolving around the drugs though, because I heard from a doctor at my practice today that you could use anisetin and yohimbine intermittently, like they would both work the same way to reverse the same drugs.
I am sure you probably could, but I know that's not a on-label use. You know what I
So
mean?
it'd be more off-label
Yeah.
essentially.
Yeah, I'm sure it would probably work somehow, but would I want to do that? I don't know. I don't know. It definitely wouldn't be a VTNE question like, can you use, like, so I guess I have not seen that. But I wouldn't be surprised if someone's done it, if they had to do it. So, yeah.
Okay.
But that's interesting.
I thought the same thing. I was very confused when I was informed. I was like, wait, what?
Who's that? Galaxy 10 Plus?
It's Nikki.
I know. I was like, you sound familiar.
I had to hop on. I need the review.
It's funny when it's your student. From her voice. That's so funny.
I didn't even talk that much in school.
I know. That's great. Everybody else feeling at least a little better? Somewhat. We got
Yep.
through a week, 2 weeks. Any questions from additional homework or quizzes or your own studying?
I have to also say I really appreciate you posting the extra work and stuff, because we had it during our math course, and then we also had it with our anesthesia course with the fluid rates and stuff, and I really appreciated the cheat sheet, and then also just having the extra practice problems, because it feels like they're so stingy with the practice problems, and I'm like, but please let me practice. Yeah.
You know, I've never had anyone be so happy to do math, so I appreciate that. Absolutely. Yeah. No, it's great. I mean, I'm always happy to come up with new stuff for you guys and put it on there, because, I mean, the more that we can repeat it for each other, then the better you guys are going to be at it, and then the less anxious I think you'll be when you have to get in there to take that VTNE. Especially on those things that you weren't confident on. You know, I think math for a lot of people it's not their comfort. So finding different ways to do math and make it work for you is what it's all about. You don't have to do it the textbook way all the time. You know, as long as it makes sense to you and you can get that answer and you're able to explain that answer, that's fine. You know, so. And you can point out all my mistakes like someone did in one of the things, which I was like, wow, I totally screwed up. That's awesome. All right, well, I won't keep you guys. So I appreciate you guys again for jumping on with me today. Please message me for ideas of what you guys, additional things you want to learn about. Of course, we'll continue doing these as long as I have people that want to do this stuff, and I'll keep posting things for you guys to keep practicing on. But I appreciate you guys and your willingness to continue learning and doing this. So thank you. And I'll post this video as well for everyone else who missed it today, and then you can give them a hard time for missing it. But but thank you again for joining.
Thank you.
Yeah, take care.
Thank you. Thank
Yes,
you.
of course. Bye.
Thanks, Beth.
Of course. Bye.
Bye.